Hi, everybody. Thanks for joining in today. My name is Talisha Smith-Gorby, and I'll be your instructor for Clinical Epidemiology 5 on diagnostic tests. The objectives for these sessions is to gain an appreciation of the properties of diagnostic tests, including concepts like sensitivity, specificity, positive and negative predictive values, likelihood ratios, and receiver operating characteristics. We'll also review the principles of diagnostic test interpretation and review and examine issues of measurement error and bias as they apply to diagnostic testing. So let's start with part one. We'll do an introduction and talk about sensitivity, specificity, and predictive value. So here's some questions to consider and thinking in the context of our lives in medicine and in the emergency department. What is the goal of diagnostic testing? Well, we do diagnostic tests as much as we can to try to determine what the truth is. And the truth can be different things. For example, could a patient have a pulmonary embolus? Could they have a kidney stone? Could they be having acute coronary syndrome, for example? And so what qualifies as a diagnostic test? Things like our history, physical, lab investigations, and imaging, and even a combination of any or all of the above do qualify as diagnostic tests. So why develop a new test? Perhaps the new test is needed because we need something that's more accurate, or more reliable, or cheaper, or more acceptable to patients or clinicians. And if you have developed a new test, what you'd like to know is how well it compares in diagnostic ability to the gold standard or to the reference test. Ideally, we want to compare a test to a gold standard, what the truth of a condition might be. And so what are some examples of gold standards? Things like autopsy, biopsy results, cultures, and some radiologic tests, for example, counts as gold standards. Sometimes, however, though, there is no good gold standard, or perhaps it's too risky or too expensive, and so you might have to compare a new test against a best currently available test. And this can be problematic. For example, if the new test is more sensitive than the old test, and we'll cover this in a bit, but let's say this new test is better at picking up a condition when it exists, compared to the old test, it might be considered a false positive, for example, although they are correctly true positives. And if you don't know that your new test is actually better than the old test, this is a problem. And you might think actually that your new test is actually worse and you shouldn't be using it, but maybe the new test actually should be the gold standard. So the goal of test development is to make a test that's highly reliable and accurate, but minimizing cost and risk and patient discomfort. And ideally, and if you can, it'd be great if your test can identify a disease or a condition sooner so that earlier intervention might be possible. But it's really important to understand the properties of diagnostic tests and how they interact with our clinical setting to make sure we understand how to use them properly. Ideally, the results of a test will reduce uncertainty and you'll feel better about either making or not making a diagnosis. But there are times, for example, that a result of a test might actually make it a little less clear as to what's going on. For example, we've all seen a low-risk chest pain patient who somehow gets a D-dimer sent and it comes back positive. So now do we think they have a pulmonary embolus? Do we think it's a false positive? Is something else going on? Now we're not as sure as we were perhaps before we had the test result. So every day in the emergency, we do this so many times an hour, and I think we do this without even really thinking about it too much to a certain extent, is that we have a test with its particular properties. You apply the test to a patient, you get some test results, and you make a treatment decision. And although it looks very simple, just a bunch of arrows on the slide, this is a very complex process. Things we do while thinking about it, while not quite thinking about it subconsciously. This is quite a complex process, actually. And the result you get in the end is often a probability of a condition or not having a condition, as opposed to an absolute certainty. I mean, there's very few times I think a test result 100% tells you what's going on relatively. For example, if you have a patient who's fallen, they have a clearly deformed forearm, and they have an x-ray that shows a displaced fracture, then the x-ray result shows with certainty there's a broken bone, but usually, as we all know, medicine isn't always that easy. So let's do an example. Let's pretend that you're the coach of a recreational hockey team, and unfortunately, you lost the last season in very last place. And the only game you won was by default when the other team didn't show up, unfortunately. And so, what you'd like to do is identify the best players to stack your team for next year so you can win the championship. And let's pretend that there is a blood test that will tell you if someone is a hockey star, which is the hockey protein. And let's say if you're hockey protein positive, you're a hockey star. But if you're hockey protein negative, you're not a hockey star. And let's imagine this test is very expensive and it's time consuming. And so you go to your garage laboratory, you develop a non-invasive test, which is a hair sample. And you want to know how well this hair sample performs compared to the blood test. So you manage to round up about 500 players from across the city. You draw their blood and take a hair sample, and you want to know how well this new test performs. So these results you get back. You have on this area here, the results of your blood test, so positive and negative, and the results of your hair test, positive or negative, and the results of the testing you've been doing. So now what? You have these numbers. What are we going to do with it? So let's talk about properties of diagnostic tests. And this should be a review for pretty much everyone. This should be covered in medical school, but let's review it anyway. So this is the famous 2x2 table, which I'm sure you've seen before. You have on one side truth, which is we take as the gold standard, versus your test results. So positive test for the gold standard, negative, and then for the test you're comparing it to, the positive and negative as well. And so you have 4 different cells. You have your true positives, your false positives, your false negatives, and your true negatives. And sometimes you will see these cells labeled with letters A, B, C, or D. I strongly recommend against just memorizing what each letter in which box is, because someone could very easily change the orientation of the table. So it's always good to be able to say what each cell means, whether true positive or true negative, for example. So let's talk about sensitivity. What is sensitivity? Well, sensitivity means of all the people who truly have a disease, how many do the test correctly identify as actually having the disease? I've always found it easier to be able to say these equations in a sentence, and if you can say it in a sentence and it makes sense to you, it's much easier to remember and figure out how to apply it. So other way of saying it is true positives divided by true positives plus false negatives. And so sensitivity is a function of those who truly have the disease. We don't know anything about the false positives because sensitivity is only calculated looking at those who truly have the condition. And it's important to know that a 90% sensitive test doesn't mean that your patient has a 90% probability of having the disease. All it means is that if your test is 90% sensitive, if your patient truly has a condition, there's a 90% chance the test will pick that up. So going back to our hockey hair study, let's try to calculate the sensitivity. So of all the people who truly have the condition, these cells here, how many do the test correctly identify as having the condition? So we do some math, shakes down to 83% sensitive for detecting a true hockey star. So out of 100 true hockey stars, 83 will be correctly identified as being hockey stars based on this test. So you may have heard a mnemonic called SNOUT, which means when a very sensitive test is negative, the disease is ruled out. So SNOUT. And it seems a little bit counterintuitive to think about a sensitive test which looks for a condition being negative, but how SNOUT works is it means is that a very sensitive test has very few false negatives. So for example, if you have a test that is 99.5% sensitive and you test negative, there's a 0.5% chance of you being labeled a false negative if you truly have a condition. So it's a low chance of being a false negative. And that's why if you have a very, very sensitive test and it comes back negative, you're most likely a true negative. And that's more helpful as a rule out. If you'd like to see the equation, if it helps to try to figure out why a very sensitive test has few false negatives, so sensitivity will range between 0 and 100%, so 100% being a perfectly sensitive test, which has no false negatives. The closer sensitivity gets to 100%, it means this term, the false negatives, needs to be very, very small. because you know when you divide a number by itself, it's equal to 1. So to be closer to 1 or to 100%, the false negatives need to be very, very, very small. And that is why a very sensitive test, if negative, can help to rule something out. And you see this in asterisk, and of course, like in medicine, there's always caveats, and we'll cover that in tutorial. Now, there's a concept I'd like to go over of the 1 minus sensitivity, which, if you're like me in medical school, this made absolutely no sense. And especially when you're talking about likelihood ratios and having to memorize equations for the LMCC and 1 minus sensitivity, what's all that? So let's cover what this means now. And if this is a review for you and you got it, feel free to skip past this part. So 1 minus sensitivity is the false negative rate. So remember, sensitivity means that all the subjects used to calculate sensitivity truly have the disease. So for example, if the sensitivity of a test is 70%, we know the test is going to pick up 70% of the people who truly have the condition. And the remaining 30% will be the false negatives. So for sensitivity, remember, this is all we're doing is sensitivity. So we know all these folks truly have the disease, minus the 70% that the test correctly identified as having the disease, the true positives, leaves you a 30% false negative rate. And that is 1 minus sensitivity. If it helps you to see it graphically, here are some very simple pictures. Same idea, all of these 10 subjects truly have the disease. The test is 70% sensitive, so it correctly identified 7 subjects as truly having the disease, these 7 folks here, leaving 3 of the 10 as false negatives, because they all truly have the disease, but the test missed these 3 people, so the false negatives. So 1 minus sensitivity being 30%. So keep that in mind, we'll cover it more in likelihood ratios. So for our study, the false negative rate, 1 minus sensitivity, 0.17 or 17%. And we'll talk about this later, as I mentioned. All right, now let's talk about specificity. So specificity is all the people who truly do not have a disease or condition. How many will the test correctly identify as not having the disease? So in the equation is true negatives divided by true negatives plus false positives. And it's also expressed in a percentage. And now this is a function of those who are truly free of the disease. And so we don't know anything about the false negatives because everyone in the specificity calculation truly does not have the condition. So in our hockey hair study, let's look at the specificity of all the people who truly do not have the condition. So this is our gold standard, negative. So these are the folks who truly do not have the condition. How many are correctly identified as being negative? So this is the true negatives, 100 here. So if we do the math, turns out to be about 25%. Not great. So our hockey hair test sample is relatively sensitive, and compared to the specificity, it's relatively good, 83%, so not as many false negatives, but it's not very specific. Their specificity is 25%, meaning there's lots of false positives left, meaning it's calling a lot of people hockey stars who really actually aren't hockey stars. Maybe they're good at golf or ringette or lacrosse or something, but not very good at identifying the hockey stars. It's calling a lot of people positive who aren't. So now let's talk about the 1 minus specificity. So we've seen the 1 minus sensitivity. Let's talk about 1 minus specificity. And so 1 minus specificity is the false positive rate. And it's the same concept really as 1 minus sensitivity, but now we're on the side of the subjects who truly do not have the disease. So for example, if we have a test that is 60% specific, we know that everyone in the specificity calculation truly does not have the disease. We take away the 60% that were correctly identified as not having the disease, leaves a 40% false positive rate. Same graphic idea, all these 10 people do not have the disease. The test correctly identified 6 out of the 10 as not having the condition, but it said 4 out of the 10 do have the condition when they truly do not. So a 40% false positive rate, or the 1 minus specificity of 40%. So in our study, the false positive rate, 1 minus specificity, 1 minus 0.25 gives you 0.75. So the other mnemonic you might remember from medical school is SPIN. And the phrase that goes with it is when a very specific test is positive, the disease is ruled in, which is SPIN. And why might that be? So let's say, for example, that you have a test with 99.5% specificity and you test positive. So if you truly do not have the condition, there's a 0.5% chance of being labeled a false positive. So it's unlikely that a positive test result would be a false positive. And again, if it helps to see the equation, so for specificity, the closer it gets to 100%, the smaller the false positive term needs to be. So if a very, very, very specific test is positive, it's unlikely to be a false positive because this term is so, so small. So let's compare sensitivity versus specificity. So in which scenario might you want a very sensitive test? Typically, you want very sensitive tests when you're screening for conditions. You don't want to miss people. You don't want false negatives. For example, the Ottawa ankle rules or any other clinical decision rule you could imagine. They're screening to assess for conditions. You don't want to miss anyone. So you want high sensitivity, few false negatives. And in which scenario would you want a very specific test? Typically, you want them in tests that are confirming a condition. You don't want a lot of false positives, or I like to call them the false alarms. For example, HIV testing or cancer testing, you don't want to tell someone they have one of these conditions when they truly don't. You can imagine how disastrous that would be. So something we see all the time, for example, is our friend the D-dimer. Not a very specific test, as we all know. So positive D-dimer might not help you diagnose a pulmonary embolus. Infections, pregnancy, malignancy, trauma, things like that can also cause a positive D-dimer. But a negative D-dimer is more helpful as a rule out for pulmonary embolus in the appropriately low-risk patients that you've assessed. However, on the flip side, troponin is much more specific for ruling in something wrong with the heart in general, for example. Alrighty, some more sensitivity and specificity comparisons. In a perfect world, a perfect test would be 100% sensitive and 100% specific, but this pretty much never happens, and there's a trade-off between sensitivity and specificity, unfortunately. And the question is when you're deriving tests and determining what the cutoff point is between normal and abnormal, where do you set the bar? If you set the bar too high, you might have lower sensitivity, but higher specificity. So if it's too low, you might make it too hard to diagnose a condition, but since you made it harder to diagnose a condition, you expect fewer false positives. But if you set the bar too high, you might have higher sensitivity because you've included so many folks and you're not going to miss a lot of conditions, people with conditions, but you're going to lower the specificity because now there's more false positives getting in. So it's tricky to determine where you set this bar. So let's go through an example now. And these types of tables you might see on exams, and there's different manipulations you can do with them. So let's go through one example. So in this population of 400 people, we've run a test on comparing to a gold standard. So here's the new test versus the truth, the gold standard. There's a total of 400 people. So in this population, what is the prevalence of this condition? Well, we know the prevalence as the people who truly have a condition, and which calculation tells us which proportion of people truly have a condition? The sensitivity. And so sensitivity being calculated only using those who truly have a condition, we know it's this column here. So 50 out of the 400 people have the condition, and that's a 12.5% prevalence. So what's the sensitivity? And of all the people who truly have the condition, how many do the test correctly identify as having the condition? So 40 over 50, 80%. What's the specificity? Of all the people who truly do not have the condition, how many do the test correctly identify as not having the condition? So that shakes down to about 72%. And an important thing to keep in mind is that the sensitivity and specificity are properties of a test, and they should not change based on disease prevalence. And I say should not, and in a later video we'll cover why it might happen. But in general, the sensitivity and specificity should not change. And this will be important when we talk about likelihood ratios later. So now let's move on to something called the predictive values. So let's talk about the positive predictive value. Of all the people who test positive, how many truly have the disease? So of all the people who test positive, how many truly have the disease? This is different from sensitivity because sensitivity incorporates all those who really have the disease, but may not test positive. Now we're looking at the people who test positive, how many truly have the disease? So the equation is true positives divided by true positives plus false negatives. And as we'll see in a bit, the predictive values can be affected by prevalence in the population. So looking at our hockey hair study, let's figure out the positive predictive value. Of all the people who test positive, how many truly have the condition? So 83 out of 383, it shakes down to be 0.22% positive predictive value. And the negative predictive value now, of all the people who test negative, how many people truly do not have the disease? And this is also different from specificity on this side of things, because specificity incorporates all those who really do not have the disease, but may or may not test negative. And so the equation for negative predictive value are the true negatives divided by the true negatives plus false positives. And this is also affected by prevalence in the population. So for a hockey hair study, what's the negative predictive value? Of all the people who test negative, how many are correctly identified as being true negatives? And it shakes out to be 85% negative predictive value. So as we said, why does prevalence affect negative and positive predictive values? Well, if you have a high prevalence of a condition in a population, if they test positive, they probably have the condition. So for example, if you test a patient in the middle of January from a long-term care facility for a respiratory virus and they've got cough and myalgias and fever, and there is an outbreak in this long-term care facility and their nasopharyngeal swab tests positive for a respiratory virus, they probably have it. But on the flip side, if there is a low prevalence of a condition in a population and there's a positive test, they may not really have it after all. So for example, if you are doing prostate-specific antigen testing for, let's say, prostate cancer in people who have never, ever, once in their life, ever had a prostate gland, there really should be a terrible positive predictive value because if there's a positive test, it needs to be a false positive. But we'd expect a 100% negative predictive value because there really shouldn't be any false negatives in this population. Or for example, if you're testing for ST elevation on an ECG for STEMI due to atherosclerosis in children. There's many causes, as you know, for ST elevation, things like benign earlier polarization, normal variance, or pericarditis. In the pediatric age group, those are more likely than having a STEMI because of atherosclerosis to occur, because kids generally don't have atherosclerosis to cause STEMIs like adults do, for example. So if you're looking at an ECG in a kid and he has a positive ST elevation, you call this a STEMI from atherosclerosis, it's most likely a false positive. So it's very, very, very important, looking at your predictive values, is that you need to know the prevalence of a condition you're testing for, to know how to interpret the results of your test. And the prevalence is often referred to our pre-test probability. So let's do an example about how predicted values can change based on prevalence. So here's our population of 400 people again. What's the prevalence? 50 out of 400. So we know that's 12.5%. What's the positive predictive value? So of all the people who test positive, how many truly have the condition? So these folks test positive. How many truly have the condition? 40 out of 140, meaning 28.5% positive predictive value. And now what is a negative predictive value? Of all the people who test negative, how many are truly negative? 250 out of 260, which is 96.2%. So we see with a prevalence of 12.5%, the most helpful test here is a negative predictive value. So if you test negative, you probably are a true negative because relatively few people in this population have the condition. Let's change things around now. So what's the prevalence? Same test, but a different population now. What's the prevalence? Yeah, exactly. So it's 200 over 400, which is now 50%. Prevalence has gone up 4 times. So now what is a positive predictive value? So PPV is 160 out of 216, which is 74%. What is a negative predictive value? 78%. So things have changed a little bit. We can see now that the positive predictive value has gone up, but the negative predictive value has gone down based on the prevalence. So the prevalence goes up, you start getting fewer false positives, but then you start to get more false negatives. And that's a trade-off, unfortunately, you have to deal with a little bit with sensitivity and specificity, unfortunately. So in general, a very sensitive test will also tend to have a better negative predictive value. Remember we said snout, so a very sensitive test tends to rule something out if negative. And we know that a very sensitive test has few false negatives. So looking at the equation of negative predictive value, if a very sensitive test, it has to have very few false negatives. This term is small. This gets close to 100%, and that's how your negative predictive value gets higher. On the flip side of things, a very specific test will also tend to have a better positive predictive value, so spin, as we said. We said that a very specific test has few false positives. So looking at the equation for positive predictive value, if it's very specific test, there are few false positives. This term gets very small, and so this gets closer to 100%. So that's how this works for sensitivity at NPV and specificity and PPV. All right, so that's the end of part 1. So let's do a quick summary. So it's very important to understand the property of diagnostic tests and how they interact with our clinical setting, and this can be very complex. We know that high sensitivity tests are more helpful for screening, and high specificity tests are more useful for confirmation. We reviewed that the sensitivity and specificity of tests should not change if the prevalence changes, but positive and negative predictive values will change when prevalence changes.